shut it if we need to. Hey guys, it's Jamie here with Dr. Siri.
Hi there, everyone.
And we have an awesome video for you guys today. We asked your questions about OIT and you had a lot of them. They have a lot. It's like 20 questions. I was like, this is the 20 questions game. So what we're going to do is we're going to actually we're going to try to hit all of them, but we're going to do it rapid fire, which means I have to keep my mouth shut besides asking the questions. And hey, Stephanie, and you're going to give us quick answers.
Well, we appreciate that, you have a great mouth, so we don't ever want you to keep it shut. And
well,
thank you for the opportunity to speak with you today.
That is sweet of you. Well, we appreciate you answering our questions because you are definitely one of my favorite OIT doctors in the whole wide world.
And it's not just because I talk fast.
No, but your talking fast will come in handy today. So we are going to do the questions that you guys have, and the deal is that we want you to comment, give hearts during that question. We are going to be trying to gauge which ones you want more info on as we just give a general answer to the questions. And then this will give us an idea of some more videos to do in the future, more specifically. We try not to do OIT every time, but it's always something that people here in our group know we are doing. We know we have access to you as an OIT doctor, and it's just something they like to learn more about. So I'm always letting them drive the bus, and if they want more videos on OIT, we will certainly do them. So today is going to be a great gauge. Hey guys, good to see you, and I'm going to have to be careful of saying hi to everybody all the time because we're just going to try to make this as quick as possible for our busy moms and for your busy schedule because you have patients today. All right, so let's get started. You said you would tell us really quickly what OIT is for those who don't know. A lot of people here do, but quick.
So OIT stands for oral immunotherapy. It's also another word for food desensitization. So, the concept of just strict avoidance, we're now applying that same concept that's been used in many different scenarios for drugs, for indoor-outdoor allergies, things like that, and trying to introduce small quantities into the immune system to see if we can get a less of a reaction in the future. So hence the desensitization. That doesn't necessarily mean cure. That doesn't necessarily mean the child will open eat and eat the food and not have allergies anymore. So when we talk about desensitization, it's lessening their response. For some of those kids, they will, in combination where the bodies naturally outgrow the food. But really, it's about reducing reactions, reducing that risk of a severe reaction in the future, and honestly, just relieving, anxiety, stress in your life, and being able to feel more normal, which is the goal.
That is the goal for us. So, like you said, improving quality of life, and there's another part to that I just missed. Improving quality of life and adding some protection for the kiddos. Absolutely. Is how I would describe it as a mom. And we have more videos definitely on OIT with Dr. Bob and Dr. Siri to give more detail on the definition. All right, so first we're going to talk about candidates and getting ready for OIT and who is it for. So here's our first question. Well, why don't more allergists offer it? Is there a quick answer of why we're having a hard time finding doctors that'll do it with us?
Yes, it's a relatively newer concept as far as food desensitization, especially the United States of America, with changing, practices, changing mores, a lot of, pivotal studies, changing the idea that, we shouldn't just strictly avoid. We don't know if strict avoidance, for the first 3 years of life, which we used to do 20 years ago, made things worse or not. And so with some of the newer studies, this has helped change concepts. And the reason that, most allergists don't offer it, well, number one, these are protocols and they're driven by science. So science is evolving. Number two, many people are not familiar or used to basically doing this. So unless the doctors have been specifically trained, they may not offer it. So, for example, some of your allergist immunologists may not do endoscopies and look up the nose, or they may not do patch testing for chemical contact allergies because they simply just weren't trained to do it. So, for the majority of people, they haven't been trained. And so, unless you actually seek out the opportunities and are kind of open to the idea, then many people are still not doing it. But as you see, more and more doctors are doing it, and you're noticing more and more doctors are being aggressive about challenges and things like that. And that's born out of basically our education. When we go to national meetings and things like that, there are more sessions offering how to do a proper food challenge. There are more sessions talking about the risks and benefits, how to prepare your office, and which patients are candidates. And to be actually simply more aggressive about thinking about food allergies, because it's become an epidemic, and we can't continue in this world where 12% of our patients in some areas are having peanut allergy. So it's become an issue that has really come to the forefront because of patient need.
That's that's what I was going to say. I'm curious on the education part, just for somebody going to school to be an allergist, like when will this be incorporated in? And you say it's driven by science, so.
Yes, and many of the programs, not all the programs, but many of the programs have a food center now. Stanford, Harvard, New York at Mount Sinai, and so many of the new fellows that are graduating have a lot of experience doing food challenges. Not necessarily food desensitization, but at least food challenges, looking at the blood work, thinking about those patients. Whereas before, there really wasn't that much of it other than strict avoidance.
Right, right. Reminds me of Dr. Bob tells us the story of how he set protocols as a high-risk OB that did not become standard for 30 years. And he said that this kind of reminds him of that, but hopefully it will move a lot faster than that too. Does OIT always start with a food challenge?
No, not necessarily. Somebody with a good clinical history. So oftentimes we look at, does this mean that the child is allergic when I have a positive skin test and a positive blood test? So clinical history drives everything. If you come to our office and you're like, my kid has never had peanuts, they don't have any allergic rhinitis, they have no eczema, we don't even know how we got this positive skin test and blood test. I'm not really even sure why you got tested in the first place in that case. So we have to kind of clinically correlate it. So the hardest cases are the kids who basically have a positive skin test or blood test, and maybe they're not super positive, and they've never eaten the food and they've never had a known reaction. Those are the hard ones. And in which case, since there's a discordant information about that, those kids probably should be challenged in a graded, safe way. But for the majority of patients, if they've had a pretty convincing, history, and then their blood test or skin test support that they're allergic, then those candidates clearly have a food allergy, and they're candidates for OIT.
Right. I mean, we came in with Miles as a toddler who had anaphylactic reactions. We knew he was very allergic to milk. Then he also tested really high to peanut, but never had any exposure or reaction, and we really didn't know what we were dealing with. And we used to treat those the same way. So things have changed where now they're treating them differently based on your history and your testing, and then that a challenge or not a challenge depends on all that big picture of your history. That's cool.
Right. So not all kids need a challenge. If you have a good history noting that you're allergic, then no, you don't. You don't need to start with a challenge.
Because that's the golden standard. If you proved it on your own, we don't need to prove it again. All right. An age recommendation and why to start OIT?
So some healthcare practitioners, there are a few of them out there that will start under the age of 1. Our practice, it's basically above the age of 1 or 2. And some people will only start in older children. So that's actually going to be specific to the experience and comfort of your doctor, honestly.
Gotcha. Let's see. Does doing OIT affect if you would have naturally outgrown it, or jeopardize that you could have outgrown it? Like the mom said, we don't really know that we would have or wouldn't have, but do you see any correlation there where we might want to be cautious or not?
Sure. So again, this is kind of it varies from child to child and reaction to reaction. So we know the worst thing that can happen is that a child is allergic, and we know they're allergic, and they continue to have frequent anaphylaxis, accidental exposures, because we know that allergies are an overactive immune system. Mm-hmm. I mean, it's IgE driven. You are having a bad hypersensitivity response to the allergen, and so the worst thing that can happen is that you continue to remind the immune system, like once a year, and have a bad anaphylaxis once a year when you have an accident, because it just makes the allergic reaction stronger, honestly. And so the desensitization form comes in whatever form of desensitization you think about. If you think about allergy shots, we do frequent small low doses and continue that. And so this is the same thing when we talk about the concept of food immunotherapy. It's frequent small low doses and then building up to higher doses over time. So shocking the immune system with basically huge doses all at once is a bad thing. And those kids who basically continue to get anaphylactic reactions have a tendency to persist and have severe allergies or allergies that continue into adulthood. So the question is, what about the kids who are young and maybe have a light allergy? They're not really that allergic. Their blood test, skin test, maybe they're accepting some forms of the food. Are those kids going to outgrow it? And largely we know with milk and eggs that 80% plus will outgrow it by the time they're 18. The question is, who is that small percentage that doesn't outgrow it? The question with peanuts and tree nuts, well, we know that 25% of kids can outgrow peanut allergy, but largely those kids again are young kids. And they're young, and by the time they're 5, 6, 7, we're starting to see them outgrow it. They're typically not a 12-year-old who's allergic to peanut, and then basically later on, when they're 18, they've outgrown it. That's typically not the scenario. It's young kids, their immune system changes, and then 25% outgrow it. As far as tree nuts, it's even less. Part of it is that most young babies are not allergic to peanut, but then later on, when the kids are a little older, they have more exposures, they become allergic to peanut. Now, tree nuts. So with tree nut allergy, we know the order is probably about 10 to 12% that outgrow that. So the milk and egg thing is interesting because of the modification of the foods. You can bake it, you can cook it. There can be different forms or variations of the food protein. Because of what we do with the foods. And so that, I think, in part helps to encourage outgrowing when we kind of get small pieces of that, directing to our immune system and trying to get our bodies or our gut to kind of retrain that over time. So that's why milk and eggs are different than, the traditional other tree nut, peanut, and shellfish. And so with those, given that, the child might outgrow it over time, the question is who and when. And so I think that, that's a personal decision that's based on the child. If it's looking like that they are, accepting certain foods, baked in milk, baked in eggs, it looks like their antibodies are low, their reactions are not severe, it might be over time with, a negotiated way of introducing the food slowly that child might outgrow it anyway. But certainly if they're 11, 12, they're kind of growing into puberty, they're already exhibiting signs of, anaphylaxis, and it's severe, those kids aren't going to naturally outgrow by the time they're 18.
If they're not going to naturally outgrow it, you would do OIT to help the body along with that, with like a forced outgrowing kind of thing, but in a very careful way. Or if they're having anaphylaxis and stuff, you wouldn't do OIT.
So the two populations are, is this young child possibly going to outgrow it? And, the ways to basically get them to outgrow it sooner are through OIT. And then the other population is the kids, maybe they're a little older or they're very severe or they've had a severe reaction before, whatever age they are. And then we don't think that the probability is they're going to outgrow it by the time they're older, 18, 17, 16. Then in that kid, then there's a possibility of negotiating the reaction to desensitize them to some degree with OIT.
So it sounds like OIT is a good idea, whether they were going to outgrow it on their own or not, because it's just helping the body along with accepting that.
You can even think of it in this way. I mean, you don't have to necessarily be in a formalized OIT program to think about this, but if, the child has a mild allergy, our concept is not, let's strictly avoid it and the child will outgrow it. Our concept now is, for most modern doctors in the literature that we know, is that if you're looking like you might tolerate some proteins, continuing to massage that introduction is actually going to be helpful without causing severe reactions. So if your child is getting bad eczema from a food, bad asthma from a food, anaphylaxis from a food, hives from a food, then clearly the immune system is such that, that is not the right dose. That's not, the right method. But if, we withdraw it and then do a smaller, slower form of negotiating the immune system or massaging it, then that would be more successful.
If it's working, then it's good. If you're seeing that it's...
Yeah. And the question is, OIT or not OIT? That's a personal decision. Right. Not every family, it's going to be right for them. Not every family, because there's a lot of, work. Mentally, there's work. Physically, there's work. And the child has to, be agreeable. And so it's not going to be right for every family.
I say it's a lifestyle change, honestly. For us, it's been. I'm doing a little light work there. Oh, wow. But that's really good.
I think you and I know that every single family that's gone through it, that's had success, would never turn back because it completely opens your world and it's completely different.
Mr. Miles would not turn back. Yeah. We are going to talk more about us another time because there's a lot to our story that I think people like to hear. All right. So did we say who is a candidate?
I think we did. It's virtually any child with a food allergy is a candidate. The question is, the families, honestly. If there's a child who basically had a severe reaction where they were in the ICU, I would argue that most OIT practitioners probably are not going to take your case, and you would probably be referred to a center where there may be some other options for you in combination with some of the investigational things that they're talking about. For some of those kids, sublingual immunotherapy as a bridge to that might work first. Those kind of things, and then the other patients who may not be candidates are patients with EOE. So there are a few centers that are trying to surpass that. The esophagus kind of deal. So that's different than eosinophilic gastroenteritis. So, there's what we call eosinophilic gastrointestinal diseases in general. If it's just limited to the esophagus, there are some practitioners out there who might figure out ways to kind of trick the immune system. For example, sublingual is just under the tongue without the swelling component. But if you have eosinophilic gastrointestinal diseases that affect more than just the esophagus, again, it may not be something that is compatible for you. And so all those are, kind of no-goes. So severe anaphylaxis requiring ICU admission, non-compliance, basically...
Non-compliance means the family not being able to to make the adjustments needed in their lifestyle?
Yes, so
Okay.
they, so maybe a family approaches us and they're interested in doing OIT. Well, if they cancel a lot of appointments, they don't really have an EpiPen, they, sometimes miss on their medications, their kids are an absolute allergy mess.
Right.
Skin's not controlled, they're not taking their medications, not a good candidate because this is a regimented program.
Right.
Honestly, some other, comorbidities, if there are a lot of health issues, if the patients have severe psychiatric issues, things like that, those are probably no-goes.
Okay.
And certainly, we talked also about age, which
Yes.
is another question.
Okay, you're really good at reading my list. All right, go for it. I'll
Your
cross it off
handwriting's
the
almost
list. Oh my gosh,
Yeah.
this is my messy writing.
So OIT can be done really in any age, but once they get older, it is probably less successful in causing permanent desensitization. We don't know that for sure because there aren't that many people, who are adults, past the age of 18 who are doing it. But when we're talking about some of the young kids where we might someday get to free eating, that's different than a 20-year-old who's looking for OIT to decrease sensitivity. That person's probably not going to get to open eating, But it's, there's exceptions to the rule. There's different people out there. There's different immune systems, blood work, skin tests. They're all different. And so we can't say that conclusively. But we know that the immune system is most malleable when the kids are young. And so so that's why many of the successes that you've seen in some of the clinical trials and things like that for food immunotherapy are in young kids. But, the new evolving therapy really truly is in adults. I mean, they have to do the adult studies in some of the therapies first. And so we're seeing that, that this is going to be, again, more science. So we can't say for sure, but that's what we know.
Oh, that's really cool. Yeah. So you said that EOE could be a disqualifier, but that there are some really specialized places that are trying to manipulate things to be able to desensitize even with EOE. Did you say that? Like a specialized clinic, hospital?
So they're, obviously you're familiar with the COFAR group, things like that. They're already looking at things like that.
Okay.
Kind of like, the Miles trial.
Yes.
Like the milk patch.
Yes.
In kids with EOE.
Oh,
there's
so
this trial
patches.
going on.
Yes. So
Sublingual, things that actually don't, direct the food proteins at the esophagus.
gotcha. And then these are all
in
in trial stages. But can we find doctors that are doing these things?
I've heard of things here and there, and certainly if any of your colleagues know about centers that are doing it successfully, we would love to hear about it and spread the word. But we're thinking, for example, in our kids we might do sublingual immunotherapy and not progress to OIT.
All right, so sublink, the slit, the drops under the tongue, patches. I mean, you and we could get into that a whole nother day. But having alternatives to just taking it in your mouth.
Correct. And swallowing it.
Is not necessarily because we want all these drugs that cost a lot of money, but it's because it can open up desensitizing options to more families who are more severe and have more hurdles to overcome to be able to desensitize. That's a good one. So that leads into one of the questions that we got.
As an aside before we go on,
yeah.
what is the optimal candidate? Obviously, if you have an allergy bucket that's really full, you're not a good candidate. So in our practice, just like in most practices, you have to have all those things controlled. Your asthma needs to be well controlled. Your eczema needs to be well controlled. Your allergies need to be well controlled. So that's why, if you're having a whole bunch of reactions, taking other medications, and, you're going outside and playing ball and you're having bad allergy reactions to tree pollen, you're not going to be a good candidate for IT.
No.
So those things have to be addressed. And sometimes that's kind of the error that many families come in and they're really worried about peanut, and rightly so. But at the same time, if their kids are otherwise an allergy mess, we have to make sure those things are controlled before they start new therapy.
Right. I think we've talked to Bob about that in a video about preparing for OIT and how you really have to have things under control before you start giving a child the food that they're very allergic to. And that includes environmentals, asthma, eczema, those things. So that's what makes them the ideal candidate, is when you have other things under control and the food desensitizing becomes the last step in bringing down their allergy bucket.
Right,
Yeah.
and it controls the the baseline. You know what reactions your child is going to have or is not going to have, rather than it's being all messy and mucky. And
Right,
you're just
it gives you a
well,
baseline.
He was over in
Right.
the house with cats, and we don't know if this was
Right.
his OIT dose or the cats. I mean,
Right.
it makes it all messy.
Because it's tricky. Even as an OIT mom, we have so much under control, and we still have things that are kind of a puzzle. So that does help a lot. So if somebody's getting like mouth sensations, which is one of the things that can happen when you're desensitizing, does that mean that going on to the next step, OIT, is not an option? Or do you want things to be really stable at one level of desensitizing before you move up to the next, I guess maybe is what that question would be asking in general.
Sure. So now we're shifting, talking about actually being an OIT and some of the side effects.
Okay.
As far as, if you're on a certain dose, how do you know it's safe to move up to the next dose? Largely, if you're having no reactions, it's safe. The question is mouth symptoms. So that's going to be between you and your OIT doctor as to the comfort level. But many, many kids do have some mild mouth reactions. Over time, it decreases. I would argue that, if you don't feel comfortable moving up to the next dose, just speak to your doctor about it. If you feel like, it's 2 seconds, it fades away, child's okay, then you might be comfortable doing it. But that's something between you and your doctor that you should discuss.
That's good to know, because it is a comfort level not everything is, but it's good to know the things that are, well, it's your comfort. Right. Versus this is a big deal, we need to address it more.
We were actually talking about, escalating and getting there safely. And that's the goal, is getting there safely. And getting to your target safely. And so we talked about, kind of a personal story, and we were like, slow go. And then you called it
low and slow.
Low and slow, and I saw slow go.
Yes. And then you gave it a foreign name too.
Yeah, and it's the concept of, so when you climb a mountain, especially if you're escalating basically altitude quickly, for example, Mount Kilimanjaro in Africa, in order to get to the top, they always say, the locals say pole pole, which means slow, slow. And if you take it slow, because the race is with you, the race is not with anybody else. And so if you take it slow, almost everybody achieves success at the top. So, whatever your comfort level. We've even broken up our very first day, that first intense day where it's like a 6-hour updosing day. We've broken it to 2 days because, for many of our families, it was either too long to spend or, honestly, it's okay to stay at the same dose for a month, 2 months. It's okay.
Yes, I do love that. And we're going to talk more about that because that's what I think sets you apart from a lot of allergists is we both are willing to do the low and slow. And so that's why we brought our group on that journey, because it's a little bit different than what we're seeing out in general, and I want people to know that, hopefully it becomes more and more of an option, because it's something we talk about anxiety in our group a lot, which I didn't know I had, and it just helps me a lot. It helps my kiddo, and it helps us see a success sooner and have more fun, and you're willing to do it. And so I think you're doing I think you're doing something very unique. From hearing all our moms and our community, I don't hear it very often. So we want to share what that looks like, because hopefully it'll become more and more an option. I don't know if this might have been with qualifications, single versus multi OIT. Quick thoughts on that. Like if you this person had a toddler with 6 allergens. Do you prefer to does low and slow mean you prefer to do one allergen at a time?
That's a good question. So there are, many, many centers where they don't mind doing multiple ones. And so again, that's experience and time as far as your doctor. In our center, we start one at a time, and you can do multiple eventually together, but we usually start one at a time because we want to see if there's a reaction to something. And so some places they'll start them together, but oftentimes tree nuts are mixed because we consider them mentally as the same thing. And so that's the one where oftentimes it's kind of multi together.
I was gonna say, does it depend on the foods? On if it would be a multiple or a single too?
I think there are a lot of factors, and again, it depends on the child, their allergenicity, those kind of things. Okay. Yeah. And so I think that again, you should discuss with your doctor if you do want to do multiple. But at least in our practice, we do one at a time, and then eventually you can do multiple.
Right. Okay. Right. Because we're doing milk first, and then we may do all the nuts for Miles next. Okay. Yeah. Mm-hmm. Where are we at? We're on side effects, Dr. Siri. Any firm info about reactions during OIT?
Oh, I'm sorry. So the question for that previous question you just had was, is there a benefit risk problem? As far as we know, doing multiple OIT together, there's no issue with it. There's no concern about it.
Gotcha.
So if you wanted to do milk and egg together and your doctor chose to, do multiple tree nuts and milk and escalate together, we don't see any necessarily any harm with all the other, factors involved. Is it going to be more beneficial, less beneficial? And really, I don't think that it would be either one. Yeah.
And perhaps if they're offering multiple, they have more experience, hopefully, in this kind of treatment, right? Yeah. That's a confidence thing that they know they can, that they have success doing that.
Correct.
So any firm info about reactions during OIT?
So, there, of course, you guys have all seen the recent, Lancet article. We can talk a whole another video about that one.
Yes.
So that's, they did, obviously, a look at, some of the published clinical trials, and they've done, some experiential things based on Dr. Wasserman and Dr. Wyndham and Dr. Jones, who went together and published that one, about, real life OIT. And so we'll have more and more info because obviously that working group is trying to accumulate, real life data rather than just clinical trial data.
Is that out or is that coming out?
Well, they've actually had some publications about their experience, but certainly I think the crux of the article that was published in the Lancet, I think it was authored by a Canadian fellow, was really principally the immune trial with the peanut OIT, the CODIT, the CODIT therapy that they have. And, in a clinical trial, when you have a regimented fashion, when you have, not, that ability to basically, change protocol that much, you may see some reactions. But again, we're talking about different populations. We're talking about kids who are having reactions in a controlled setting versus you're out in the world and you're doing strict avoidance, and then your child goes to a birthday party and has a reaction and you're not in control.
Right.
We're talking about
it gathered all that.
Yeah.
Right.
And
it's like 12 different studies or something. It's the way they were kind of analyzing overall. So you're saying it was a lot of scenarios all thrown into one. It
was different scenarios, but I think principally the gist of basically anaphylactic reaction, a lot of that came from, because it was the largest OIT study, that has been published, that is. And so that had the most patients in it. And so a lot of the data that comes from that, with peanut OIT, you're going to have more anaphylaxis. Well, that's true with any therapy that you choose, whether you talk about allergy shots, versus like out in the world sneezing on trees versus getting allergy shots in the office. There's going to be more of a risk when you choose any kind of interventional therapy. But the question is, what scenarios are we talking about? We're talking about kids who are basically getting, their dosing at home. They have some mild reactions. Those parents are already on threshold to treat. They already know what they need to do. And so those things are obviously going to be more reported than the public, for example. So many of our patients will have reactions at home, and they'll have it, at the birthday party or at the soccer field, and they won't necessarily report it to us.
Okay.
So the question is, baseline anaphylaxis in a population versus, when you're doing an intervention. But also it's different. If you're doing an intervention, those kids are prepared. They have their medications ready. It's in a controlled setting. They can treat it promptly. This is not like they went to a birthday party, they had a reaction. So that's not what's reported in the clinical trials. It's reported based on therapy. So it's not really apples to apples when you're doing that comparison.
Okay, so there's nothing really that we can...
Well, we can say that, if you start any interventional therapy, there are going to be risks to it. But that's with anything that you do. Yeah.
One of our moms said it so plainly, which she said, that's like saying that people who get in car wrecks
shouldn't be driving cars.
are the people who are on the road riding in cars.
Right. Yeah. If you choose to get in a car, there's a risk of basically getting a car accident. But if you choose to walk everywhere, you're probably not going to get in a car accident. So yes, whoever that mom was, you're right on. Right.
So I would need to speak more to, is it worth taking these risks to do OIT? Yeah. Do they outweigh are the benefits outweighing the risks?
And I don't want to minimize the fear factor. I think this is a nerve-wracking thing for everybody.
It is totally.
But if you think about the nerves and the fear going into it, which is why I think such parents seek OIT to begin with, because it's impairing their life, frankly. And for many of the families where it's very laissez-faire, the child has mild allergy, whatever, it's not impairing their life. So no, they don't need OIT. Right. But for many parents who it's impairing their life, it's affecting their child, they're being socially ostracized, those kind of things. You want to think about, can we improve this? Right. And largely, I can't think of anybody who has regretted it. It's possible they're out there, but for somebody who successfully achieved it, their world is quite different.
Right.
So
I say, it sounds negative, but I say a lot that the world of allergy is about picking the lesser of two evils. It's not like we can just have some cure that's going to make us normal like everybody else. We're always having to choose the pros outweighing the cons, and what direction is that going to take us with medication and treatments and lifestyle. It's like there's no magic pill. Like something's going to kind of suck to have to go through this process. But what sucky process do we pick over the other crappy processes? So,
and frankly, if you want to choose strict avoidance, there's no wrong answer.
There is no wrong.
That is completely the right answer. If that's right for your family, strict avoidance is also a right answer.
It is
so
a
you
right
don't have
answer.
to feel pressure.
And we did that for 11 years. So, and I was like silver lining mom. Like, this is great. Like, we strictly avoid, we don't go to school, we don't take vacations. But you know what? I have come to peace with that. And I'm okay with that. And I'm trying to instill that in my child, that life isn't perfect. And then our story is the child hit this wall where emotionally and mentally it was not good anymore. And we've had several moms I've talked to where that kind of changes the whole thing, because you're just like, well, I was content with this, but this is your life. And if you're not content with it, then yes, we will look at options. So I digress. Back to our questions. What if casein and whey are both high? Is that a candidate? We're back to candidates. Sorry.
Yes. Okay. Yeah. No
Is that a candidate for OIT?
So blood test, skin test. I mean, just based on that, information alone, the casein being high, the whey being high, I can't say for sure because I don't know what the total IgE is.
Okay.
And I don't know what the reaction history is.
Okay.
Yeah. So if the child just has a plain high blood test, by itself, does it sound like they're going to be allergic and fail a food challenge? Sure. But, if their IgE total is 5,000 and their, casein is like 50, that's not really that substantial. So, and I'd have to compare a skin test, blood test. So a blood test alone is not a no-go.
Okay.
Obviously, given most circumstances, let's just say the child is truly allergic, they have a high casein, high whey, and high total IgE to milk, and that's the only thing they're allergic to. Is that person not a candidate for OIT? I would still say no, not necessarily. We talked about the patients who are not good candidates, and so otherwise they could be good candidates.
Okay.
It may be that they have to go slower.
Did we talk about, that kind of goes into the next question, like the Xolair and the things that can help.
Yeah.
Some of the moms are wanting to know about that. So if you have a candidate that's very high risk, is that what you would say? Are there things that you can do to help their bodies along to accept an OIT?
I gotta say that your moms are pretty educated. I mean, this stuff is being done in clinical research, and not a lot of people know about these.
They are.
So omalizumab is a biological agent that's directed against the IgE molecule, which is the allergic antibody, and then Dupixent is a biological drug, which is drugs against two cytokines that drive allergic response as well. They're called IL-4 and IL-13. So those two specific drugs are currently being investigated in clinical trials in conjunction with food allergy desensitization, OIT. And they are being studied as monotherapy, which means you give them that drug, plus you try to do desensitization, and what is the rate. And those are being studied right now, so I don't have a comment about them.
Okay.
We think, of course, that they are probably going to be beneficial. We know from previous omalizumab studies that were interrupted early on. This was 10 plus years ago, where they actually used omalizumab in peanut allergy specifically, and the kids doing monotherapy on that medication were allowed by itself to actually tolerate more peanuts in food challenges. Now, for many different factors, that study was interrupted. They stopped studying that. Part of it, cost benefit, things like that. There were also, just to be clear, back in the day, 15 years ago when the study was being done, there was a death during a food challenge for a peanut allergy. So I don't know if that kind of contributed to basically them interrupting that trial. But now there's reignition of basically the interest in using biologics to get kids to where they need to be. And certainly Carrie Nadeau, in conjunction with UCLA, are doing some great work, doing multiple food allergens all at once with omalizumab. So this is what I know. I'm not investigating either one of those trials, so I can be open about it. And all I can say is that if you have a doctor who's doing it, cheers for you, because right now it's all investigational.
Okay. And is it dangerous for girls to do OIT that are in the ages of puberty?
Okay, so in terms of a reactions, those are one of the things we talk about. So we talk about the waiting period, exercise making things worse. If you have an infection, fever makes things worse, meaning increases the risk of reaction. And then the question is about menstruation. We can say that there have been reports of basically girls having menstruation and having slightly increased reactions. This is always the question. Biologically, does it make sense? Is it because they're also taking, nonsteroidals on top of that while they're having menstruation? We frankly don't know. Does the temperature go up when you're either ovulating or menstruating in your body? We don't really know what the factor is, but there are some case reports of basically people having more reactions of, anaphylaxis or allergic reactions in general when they're menstruating. Largely, we treat girls and boys just the same. And, there are lots and lots of girls out there going through, desensitization, allergy shots, things like that. From an allergy shot perspective, I have not seen an increase when women are menstruating, frankly.
Oh, okay, right.
And
because you give a lot of allergy shots.
Oh, lots.
And there's a lot of women.
Over the years.
And
Thousands.
Yeah, okay. And that's not something you see reported
That's
with
not something
shots.
I've seen reported. So, perhaps there's something special about that. I don't know whether, there's different scenarios about it. But certainly we think about, those reactions, exercise, fever, not feeling quite well, maybe taking new medications, those kind of things. And I don't know if that's more relevant than actually their menstruation thing or not.
If I was a mom, like I'm doing, a boy right now that's about that age, if it was me, I would maybe not updose on that week or something. Just some common sense things to, help it go a little better. So, okay.
And even
so
from clinical trials, like Amy's clinical trial, DBV, so they have had some older children and things like that in the study. They haven't seen that either.
All right, we know this one's going to be tricky. We'll try to be fast on it. Having a cough, an itchy throat, how do you know if it's sickness or you're having an allergic reaction when you're doing OIT? Do you keep dosing during that? I've dealt with this over and over again in the past year. Miles has had sick time and not knowing, and the question is, how do you know? And I don't know if you do know.
So the question is, how do you know, and then what do you do? So the question is, how do you know? So, really it's about knowing your body, knowing your child. So if your child has a baseline reaction, they have no problems, then all of a sudden they dose, and within 30 minutes they're having, symptoms, then, so you have to think about timing and introduction. Just like if you just have gone over to your friend's house, and it's been 3 hours since you updosed, and your friend has a cat, and your child's allergic to cat, and they start coughing and sneezing, odds are it's the cat and not the dosing.
Right.
But, so it's about timing, probability, cause and effect. So all those things you have to think about. So that's why most people, if they're going to dose, they should do it in a controlled setting. They're at home, everything's peaceful, quiet, your child, your child's symptoms, even if they're young and they don't communicate that well. And then, you observe them for a little while.
Right.
So that's why we say try not to do too many things, especially if you're doing a brand new dose.
Keep things simple, keep things predictable, keep a routine. And I said maybe keep a journal so that you can go into your doctor and say, this happened, this is what was going on. A lot of times you guys will help me look at the picture of what was going on. There was one time we brought Miles in, he had some problems, and one of your PAs kind of said, well, has he been getting enough sleep lately? And I thought, we haven't thought about that one. And he hadn't been. He'd been staying up late. He'd turned 13 and just had this thing where he started staying up late, and I'm a night owl, and I'm like, dude, we'll hang out in the evening. And I was like, he is not getting enough sleep, because then he would wake up the same time. And so that was great that she asked that, but that was us having lifestyle talk about during this OIT treatment to look at the whole picture. And our group is great. We're little private investigators. We are good at keeping track of everything that's going on. And so there's no total way to know, but the more diligent and careful we are, the quicker we'll be able to figure it out.
And don't be afraid to call your doctor. If you don't know, frankly, take them in. Call your doctor, ask them. I think people are, nervous about asking. But if you, frankly have investigated, thought in your mind, obviously your doctor doesn't like it if you call them every single day. But
right.
But they're going to be there for you, and they're going to appreciate the fact that you've reached out, and then they'll you'll learn some things for the future to treat your child otherwise. So the question is, do you keep dosing?
You learn, and then you can apply it the next time, because inevitably these things come over and over again. Yeah.
So our rule is that, if the fever is, less than 100, easily treated, give them ibuprofen, Tylenol, things like that, if it's appropriate, and, their fever basically goes down, then you can go ahead and dose. So honestly, it's almost like treating it. But if they're having high fever, if they're really sick, they really should be held for a day or two, however long. And then once the infection subsides, like strep throat or whatever, they've been treated, then we can go ahead and redose. But that's typically our rule. If it's mild fever, easily treated, we'll reduce the fever first and then dose.
Yep. We actually went through that with you, and you made it really easy, like the fever and the infection and what to do. All right, last one, and we say this could be a whole topic someday. At what point is cross-contamination cleared when you are doing OIT? And you said this is yes, I put a big star by it, because you're like, we can do a whole video on that later. So I think that would be good, but we have a quick...
That's $100 million question, yeah. So generally, I think that, if you're going through this process, there's the goal at the end of the rainbow. The goal at the end of the rainbow is to have no reactions ever, to be more confident, to have less reactions. Obviously, you're still going to be careful. You're going to carry your pen, you're going to read food labels, things like that. But what we want to know is, does this in general, we think about all those horrible preventable deaths of all those kids who basically had a small quantity exposure and then they died. And this is horrible, absolutely 100% preventable and horrible. And so, the big question is that with things like OIT, immunotherapy, changing the way, early introduction, are these deaths going to be stopped? And that's what everybody's interested in. Can we stop these? Because that's the worst thing that can happen to anybody on any planet. And so, the question is, can you then, be more comfortable? So, frankly, if you're eating 5 peanuts a day, a peanut a day, 2 peanuts a day, and you accidentally eat, a scoop of ice cream that has contamination with peanut, there's likely going to be less than 1 peanut in that. Mm-hmm. So, with the exception of granola bars, okay? Granola bars are, granola bars are always off the table because there's all sorts of weird nuts. But all of the food products, whether it's a bag of chips, whether it's basically cookies in a container, if it doesn't say peanut, but maybe it's been processed in a factory with peanuts, it's likely not going to have more than 300 milligrams or 250 milligrams of peanut in it that your child has accidentally eaten. So you have time to catch it. So yeah, if your child is up to 2 peanuts, 3 peanuts, I would largely say, yeah, it's much more comfortable in the world. You can basically buy products, and as long as they don't say peanut in it, even if they were processed in a factory, it's likely not going to have more than 250 milligrams.
So as you're going through OIT, at some point your doctor will say cross-contamination, may contain labels, going out to eat, ordering allergy-free, but if something got mixed up,
you can be more comfortable.
You
still
can
have
be
to
more comfortable, yes. So
And-
that does come along in your OIT journey where your doctor, we've gotten it from you where, okay, now you can go to restaurants, you can order dairy free, and you should be, because we reached a certain point, it depends on the allergen at what point, and it depends.
And this is the point of desensitization is raise your threshold for a reaction. Mm-hmm. This has been proven in multiple studies, whether it's, the commercial studies from these pharmaceutical companies, people like the University of Nebraska as a food center, they've studied this. We know they've surveyed a bunch of different foods, whether it was ice creams, cookies, cakes, things like that. And they've looked and measured for, not ones that actually contain nuts, for example, but ones that, just in general, as far as contamination levels. And largely, it's going to be less than 1 peanut contamination in it. And so if you get to that threshold, and you're comfortable with that, then yes, life is much more beautiful and much easier to negotiate. So again, with other food allergens, egg, milk, things like that, we can talk about that too. But again, largely if the food does not contain the food product, we don't know exactly what the milligrams are, and they're going to be outliers. There are going to be people who are super sensitive, and people who are less sensitive. But if the food actually doesn't say that it has it, largely if, for example, we talked about lactose. Mm-hmm. If the packaging says it has lactose, and we talked about pharmaceutical lactose, there might be some contamination with milk protein, even if they did good manufacturing practices. Well, if you're going through milk desensitization, you're drinking a quarter cup of milk, you don't have to worry about lactose contamination in small quantities in a pill that might have some milk protein because you're drinking a quarter cup of milk.
Right. So, those are the things when you talk to me during our appointments, I'm just like, oh my gosh, I didn't think about that. So that's very cool. Yeah, I still have Miles check his food when we go to, somewhere. I'm like, check it. Make sure they didn't put a slice of cheese on the sandwich that's not supposed to have it. That's not contamination. That's your order being wrong. So there's a difference in that. But we still have to be diligent for the big pieces. But we have that protection now for the minuscule accidents or contaminations that would have been a big issue for us at one point. And
we still, of course, have to teach our kids to be careful. So they, if they're teenagers, they can't go out to a slushy shop and just order something and not think, oh, there's milk in it. Absolutely not. If they're milk allergic. Right. But at the same time, is it, they can order the milk kind.
And that's what I want to share in our group at some point too. And we do a little bit here and there as we make the progress. But for us, it's not that we have let our guard down or that OIT has made us not have to think about or worry about or stress about. We are just as diligent with OIT as we were with strict avoidance, but it's a different kind of diligent, and there's more rewards to that diligency than when we were strict avoidance diligence, because there wasn't a lot of reward with that diligence. Now we have some reward where we can eat pizza and we can do things with friends and we can go to events, and those are the rewards that come with working hard to be safe. Fantastic. All right, we got all our questions answered. We still want to go on the public real quick. So like literally a 5 or 10 minute video, and we're gonna have to decide what it's gonna be about. So you guys, I hope this was helpful. After watching this whole insane rapid fire, we wanted to do this because you wanted to do it and they had lots of questions, but we do want to do more videos where we break it down to something that we can really dive into. But we had to just catch up on all the OIT questions. So we are going to leave comments. Let us know what you want us to cover more in depthly. Anything that might have been confusing that we can clear up for you. We hope overall the information was super helpful for you. We're going to go on the Public Milk Allergy Mom page. We're going to answer one quick, easy OIT question because we like to at least put something out there for the public to be helpful. And we appreciate you guys being here. And thank you so much, Dr. Siri.
Thank you.
We'll keep doing this for sure.
All right, thanks.
Bye.
Thanks, everyone.